My name is Sandeep Patel. I'm from Duke University Medical Center in Durham, North Carolina, United States of America, and today I'll be talking about Hodgkin lymphoma. The learning objectives of this talk include recognizing the epidemiology, risk factors, and clinical presentation of Hodgkin lymphoma, understanding the diagnosis, evaluation, and treatment of Hodgkin lymphoma, and identifying the long-term survivorship issues related to improved prognoses in this disease. I'll begin by discussing the epidemiology, risk factors, followed by the clinical presentation, diagnostic evaluation, pathology, prognosis, treatment, and survivorship issues related to this disease. Hodgkin lymphoma represents about 10% of all lymphomas. In the United States, about 8,800 new cases will be diagnosed with 1,300 deaths. There's a bimodal distribution of incidence with two peaks, one at age 20 and the other at age 65. About 75% of patients can be cured with therapy. In the United States, mortality from Hodgkin lymphoma has fallen faster than in any other malignancy in the past 50 years. Risk factors for the development of Hodgkin lymphoma include EBV, or Epstein-Barr virus infection, HIV infection, immunosuppression, which can often lead to the loss of T-cell mediated anti-EBV activity. In addition, autoimmune disorders and family history are considered risk factors for this disease as well. The cardinal features of Hodgkin lymphoma are painless lymphadenopathy and the so-called B symptoms of fevers, night sweats, and weight loss. Pell-Epstein fever is a cyclic fever that lasts days to weeks before remitting and recurring. In addition, though not a classical B symptom, severe pruritus may be a poor prognostic sign and often precedes the diagnosis of Hodgkin lymphoma. Hodgkin lymphoma also has several paraneoplastic phenomena associated with it. This includes minimal change nephrotic syndrome. More interesting, with the consumption of alcohol, patients may notice pain at sites of lymphadenopathy and in their bones, which is unique to Hodgkin lymphoma. The diagnostic evaluation of Hodgkin lymphoma involves lymph node biopsy of the affected tissue. Excisional biopsy is preferred as pathologic diagnosis involves both assessment of cells as well as lymph node structure. If excisional lymph node biopsy is not feasible, core needle biopsy is reasonable. Fine needle aspiration is often insufficient for pathologic diagnosis of this disease. In addition, in the age of increasing molecular tests and additional immunohistochemical markers for cancer, fine needle aspiration rarely provides sufficient tissue for these important tests and thus should be viewed as a last resort in tissue diagnosis not only for Hodgkin lymphoma, but for all cancers. Bone marrow biopsy is suggested for patients with cytopenias or with high-stage disease. PET-CT at time of diagnosis is important to assess for the extent of the disease, as well as to help assess post-treatment residual sites of disease, which may require local therapy or further chemotherapy. HIV testing is suggested as the use of concomitant highly active antiretroviral therapy, or HAART, with chemotherapy has significantly improved outcomes. Finally, as standard chemotherapy regimens include drugs such as bleomycin and doxorubicin, baseline pulmonary function testing and echocardiograms are required due to the toxicity of bleomycin, which involves pulmonary fibrosis, and doxorubicin, which can lead to congestive heart failure. The Reed-Sternberg cell is pathognomonic for Hodgkin lymphoma and is the hallmark cell of this disease. On flow cytometry, the Reed-Sternberg cell expresses CD15 and CD30. Of interest, CD30 is the target of the novel monoclonal immunoconjugate brentuximab, which is approved for use in patients with refractory or relapsed Hodgkin lymphoma. There are four subtypes of Hodgkin lymphoma. Nodular sclerosing is the most common variant. Mixed cellularity is seen in EBV-associated Hodgkin lymphoma and is more common in the HIV population. Lymphocyte-rich pathologies have a more favorable prognosis. Staging of this disease determines prognosis. The modified Ann Arbor staging system is used in Hodgkin lymphoma as well as in other lymphomas. Stage 1 is defined as a single lymph node. Stage 2 is defined as multiple lymph nodes on the same side of the diaphragm. Stage 3 involves multiple lymph nodes on both sides of the diaphragm, and stage 4 involves extralymphatic organs, including the bone marrow. Subscripts are often used to further delineate the patient's stage and have prognostic significance. The subscript B given after stage indicates fevers, night sweats, or weight loss, and subscript E indicates extranodal extension. Treatment of Hodgkin lymphoma has improved greatly over the past 50 years. As a significant number of patients will be diagnosed in their 20s, fertility preservation is important. MOP and Stanford 5 are older regimens rarely used today. In the United States, ABVD chemotherapy is the most commonly used regimen. This includes doxorubicin, bleomycin, vinblastine, and dacarbazine. Thus, it is important to assess for baseline cardiac parameters when using doxorubicin and pulmonary function when using bleomycin. In Europe, BIACOP chemotherapy is more common. This is a more aggressive toxic regimen with no clear survival benefit relative to ABVD, but oftentimes has more activity in patients with higher risk disease. For patients with relapse of their Hodgkin's lymphoma after initial therapy, high-dose chemotherapy with autologous stem cell rescue is an important therapeutic modality. More recently, brentuximab is an anti-CD30 immunoconjugate that can be used for refractory Hodgkin lymphoma. Given the relatively good prognosis of this disease, the goal of newer treatment regimens have been to minimize radiation therapy due to its long-term toxicity, as well as minimizing chemotherapy to mitigate the risks of secondary malignancies such as leukemia, heart failure from doxorubicin, neuropathy, and lung toxicity from bleomycin. As the prognosis has improved, survivorship issues such as fertility preservation are of increased importance. For patients who receive mantle radiation to the neck and chest, long-term thyroid dysfunction can occur, and thus thyroid screening is important. Also, for patients with antecedent chest radiation, smoking becomes an even more important risk factor in terms of the development of lung cancer. For women, mammography is important as radiation can increase the risk of breast cancer. Routine vaccinations and healthcare screening are of increased importance in this population due to antecedent exposures to both chemotherapy and radiation that require earlier cancer surveillance in the form of mammography and cervical cancer screening. To summarize, Hodgkin lymphoma is a type of lymphoma characterized by the Reed-Sternberg cell that overall has a good prognosis. Adequate tissue biopsy in the form of excisional lymph node or core needle biopsy is of tantamount importance. As outcomes with the use of chemotherapy and radiation have improved, efforts have been made to minimize long-term toxicities. Fertility preservation and post-treatment surveillance in the form of thyroid screening, mammography, and smoking cessation are important in the long-term survival of these patients. Thank you for your attention.